Good morning, everyone. Let me use this opportunity to thank all my mentors and AIOC for this wonderful opportunity. So I'll be speaking in favor of resection as the primary procedure in horizontal muscle surgery. So resection has been the standard, time-tested, recognized, and historically proven procedure to strengthen or tighten the rectus extraocular muscles. So here we know a measured length of this inserted tendon muscle complex is excised and the shortened muscle is reattached to the original site of insertion. So this effectively makes it more taut, improving the efficiency by raising it to a higher length tension curve. So what is happening here? There is restriction of rotation away from the muscle. Now the question is why we prefer resection to alternative procedures. Resection is a basic skill which is acquired by any strabismus surgeon. It has got a standard short learning curve and precise surgical dosage guidelines and tables are developed, and these are all evidence-based. So obviously, there is an established efficacy dose effect, and surgeons can actually combine resection procedure with small vertical upshifts or downshifts if they want to correct the associated small vertical deviations. So over time, so many procedures came up to act as a replacement procedure for section. So muscle-to-muscle tucking was tried, but it fell out of favor because of the cheese wiring effect. And then Dr. Wright described the scleral plication procedure, and that has got a revived interest in the recent past. So can plication be a true alternative to resection, and is the available evidence sufficient? So these are the concerns in accepting plication as an alternative. So as we fold the muscle onto itself, there is a hump at the plication site, and there is unpredictability regarding the post-op corrections, variability in planning surgical dosing, long-term follow-up data is yet insufficient, and long-term changes in vascularity needs to be studied in detail. And the question again is, will the effect be maintained once the sutures get absorbed? This is how a hump becomes visible at the post-operative plication site. Even though it is said that it resolves with time, it is a matter of concern, a cosmetic blemish for the patient and a matter of concern for the surgeon also. So there is uncertainty regarding the effectiveness compared to an equivalent amount of muscle resection with alternative procedures. Surgical dosage guidelines are not optimized. We see undercorrection and post-op drips also. So this is one long study which got published in British Journal of Ophthalmology, and they compared the outcomes following resection recession versus plication recession in children with intermittent exotropia. And it was found that the surgical success at post-op year 2 was 55.3% in the resect group and only 27.8% in the recession plication group. So it was concluded that in intermittent exotropia children, the resect procedure presented better surgical outcomes as compared to the plication group. The same study also found that augmentation of surgical dosage by 1 to 1.5 millimeter of the original dosage was required to obtain similar results as with resect procedure, and higher reoperation rates were also noted. Again, in another study, Dr. Wright has reported that plication is slightly less powerful than a standard resection, and he recommended increasing the posterior placement of the suture by 0.5 millimeters. So there is a disagreement regarding the amount of adjustment that has to be made to obtain similar effects. And reversibility has been hailed as an advantage of the alternative procedures. Now, Dr. Wright, in his description of the original procedure, cautions that if at all reversal has to be planned, it has to be done within the first 3 days post-operatively. At the end of 1 month, the site becomes unidentifiable. Unidentifiable means it becomes very difficult to do the reversible procedure. Now, this is another concern, effects on the anterior segment circulation. The studies hitherto done have examined only the immediate effects of plication on anterior segment circulation. So changes to blood flow may arise later when the folded muscles begin to scar. So we require serial iris angiogram studies over a longer period of time, many years out from surgery, to really comment on the effects on anterior segment circulation. And we always have this option of doing a vessel-sparing surgery in the case of resection. And this is a study conducted by Dr. Hunter himself. He compared the short and long-term changes in ocular alignment after both procedures. They have reported undercorrection and higher reoperation rates. And so many studies have come. They have compared the results between the two procedures. We see that the follow-up duration has not been more than 2 years. So to conclude, More prospective, multicentric RCTs with longer follow-up periods are required to take up plication as a real primary alternative to resection. Thank you very much.
Thank you, doctor. That was really good. Now maybe see the rebuttal from Dr. Soumya. So do you do plications or do you do only resection?
So first of all, I would like to thank AIOS and Dr. Parikshit especially for having given me this opportunity to speak on this topic. So I just wanted to ask how many of you all are doing plication here? Yeah, so our seniors itself, so that itself proves that most of the time. Yeah. So as we show here, everything needs time. And I would like to quote Winston Churchill here. To improve is to change, and to be perfect is to change often. So definitely it will take time for us to change into a different procedure. So slide is not moving. Yeah, exactly. So I hope the slides are visible. So here I am debating the most ongoing debate of plication versus resection in horizontal muscle surgery. So what do we have here? So today, you know that horizontal muscle surgery is the most common strabismus surgery that is being performed worldwide. And among these horizontal muscle surgeries, the strengthening muscle surgeries that is in view in recent times, what we are doing is resection and plication. And as our seniors have told that we are doing the standard resection procedure long often, and my opponent has already told that resection is being followed even now. So, but today I'm definitely going to prove that plication is better. So I think it's a time for changing into this. So this is what I do. It's application with reinforcement. I would like to thank Pradeep Sharma sir for this new technique, which I've learned from the Indian scenario. And basically what is done here is through what I do is through the limbal root, and you identify the muscle. This is medial rectus muscle, which I have taken. And in the similar way that we do the resection, identify the muscle, identify the points at what point you want to do a resection, and take a partial thickness bite, a full thickness bite on either side of the thing, like the routine resection procedures. The only difference between both of this is that in resection, you're basically cutting the muscle, and in plication, you're folding the muscle to the sclera. So the same thing with the 6-0 vicryl. This is the thing. You just take a scleral bite in front of the insertion of the medial rectus. The same thing on the other side. And in this special way, that is a reinforcement technique, what we do is you pass the bite from the points where you have taken. This I have not closed the conjunctiva, and in the end, you close the conjunctiva with the 8-0 vicryl routinely. So my points in favor of plication, I'm going to deal with these in the following headings. So first of all, the most common dreaded complication, the anterior segment ischemia. We know that anterior segment ischemia is very common, especially when you're including a vertical rectus muscle along with the horizontal muscles. And as a general rule, more than 3 rectus muscle is not done in a single operation, and you do not do a second surgery in less than 6 months of time. And that is why many of the anterior ciliary vessel sparing surgeries have come up. And definitely, plication does spare the anterior ciliary vessels. And this study by Deemer et al. Proves that rectus muscle plication spares the ciliary vessels. So he did an iris angiogram test wherein he showed that when you do a superior rectus, you can see that in the preoperative area, it's filling defects is not there, but in postoperative, in the superior rectus area, there is a filling defect. This is with recession. And in plication, if you can see the preoperative and postoperative iris angiogram pictures are almost the same. So there's not much of effect on the anterior segment circulation. The second most dreaded complication is lost muscle. And we know that medial rectus is the most commonly lost muscle in strabismus surgery. And why is it? Because there is no intermuscular septum between the medial rectus and oblique muscles, and which makes it very difficult to retrieve the medial rectus. And the main reason being in rectus, you're cutting the muscle. In plication, you're folding the muscle, so you can avoid that lost muscle there. So better to be safe than sorry. And I don't have to say further with this slide. So, and this study by Lambert has shown that management of a lost muscle is very difficult even in experienced hands. And the other thing is that plication is reversible, as my opponent has already told, reversible within 3 days, definitely. But you do have a chance that you can reverse the procedure within 3 days of what you have done application. So in case of overcorrection, you can always reverse your thing, but do not go beyond it. That's true. And short operating time, which is very much required because you can reduce the GA time. Whenever you're planning a multiple surgeries along with your horizontals, you're planning an oblique. So you can definitely reduce the time of operating. Then less inflammation, less cutting. And with your reinforcement technique, what she had showed was that there was a bump. But with this technique, it is almost a little more flatter. You won't see the bump there. And comparable results. Definitely, plication and resection are comparable. So I would like to quote this study, which has been recently published in 2022 in IJO, Pradeep, with the AIMS group. And they have shown that reinforced medial rectus plication is definitely comparable to that of the resection. And this is a meta-analysis study, and they have studied 7 to 8 papers, and they have also shown that it is comparable to that of the resection. And the advantage of plication is you can always adjust also, and you can also use this in nystagmus surgery. And these are my patients whom I have operated. I have been doing this since around 2 to 3 years with the same reinforcement technique, and I have definitely found good results with it. This is a large angle exotropia. This is with a V pattern exotropia. And to conclude, I would say plication is safer than resection. Additional advantage of adding a third muscle in the same setting. In case of operating a previously operated eye, the risk of anterior segment ischemia is reduced. And it's less invasive, less surgical trauma, bleeding, and inflammation. Thank you, one and all. And therefore, it's definitely time to change. Thanks.
Thank you, doctor. That was a very succinct presentation. Professor Dadia, sir.
So basically, only problem with this plication is that hump is there. So that is the one of the major drawback with this. Effectivity wise, there are various reports in the literature. It is equally effective. So basically, I think with the experience, if the persons they do this plication on long-term basis, the results will be equivocal. But I reserve this procedure only for those cases in which I want to do this adjustable surgeries.